Good morning, everyone. So I'm going to talk about AbClo like it's already been said. This is it's a preventive, non-invasive, progressive, and bedside place device for fascial closure in open abdomens. Uh, the main topic here is that this is a paradigm shift in the management of open abdomens. Different from Dr. Beckett, I do have disclosures, and there they are. And I'm going to start with a question. So, who knows what is the position or the players that are most commonly caught offside or offsides in the NFL? Okay, I can't hear anyone. So, it's the defensive linesmen. So the defensive linesmen are the most common players in the position of defensive linesmen that are caught offside in the NFL. That's because they are eager to get across that line of scrimmage and have an edge on the players on the offensive line and tackle the quarterback. This is the paradigm shift that I would like to discuss here with AbClo. We need to prevent the retraction of the edges of the gap. The sooner we get this, the more successful we will be in closing the abdomen primarily without mesh component separation or any other adjunct. Interestingly, and I've always used this slide here in respect to Dr. Beckett, who owns a Jeep, a 1942 Jeep Willys. Interestingly, this idea of preemptively or from the get-go trying to reapproximate the edge, the fascias of the edges of the fascia in open abdomens is quite old. In 1940, Ogilvy, during World War II, described this technique of his own invention here, which used canvas suture to the fascia to progressively bring the fascia together. And in his opinion, it prevents retraction of the fascial edges. This was in 1940. So what's the problem that we face today in 2023? Well, approximately 25 to 30% of patients who undergo an emergency laparotomy will end up having an open abdomen. And data from the proper trial that did not specifically investigate this show that actually looking at open abdomens in damage control laparotomy showed that among 12 level 1 North American trauma centers, there were 329 patients who underwent emergency laparotomy with damage control, and this varied between 33 and 83% of open abdomen. So it's very inconsistent across the board, the use of this technology, of this strategy, leaving the abdomen open across in North America. And that's probably the same picture here in Canada. Uh, Another problem that we face is that we're not very good at closing the abdomen primarily. This is an older study from 2013 from AAST, where 14 level 1 trauma centers were included, 2-year period, 517 patients, and only 66% of primary fascial closure. And now, if we want to broaden this into acute care surgery as well, uh, um, a systematic review and meta-analysis done with more than 3,000 patients showed that we close only 62% of those patients primarily after they have their abdomen intentionally left open after an operation. So as you can see, it ranges around that number of 60% there, our success rate. This is a problem because several studies have shown, and this one from the US as well, show that if you can close the abdomen primarily, you are decreasing complications significantly from 9% versus 60% if you use a prosthesis, and decreasing the hospital charges as well significantly compared to the other two, temporizing or using a prosthesis. I think that maybe the worst problem that you can get from an open abdomen is an intra-atmospheric fistula. And this is not uncommon. Approximately 20% of patients who have an open abdomen longer than 4 days will end up having some type of complication like this. And multiple papers show that the best way and the most effective way to prevent these fistulas is to close the fascia primarily after an open abdomen. So with that in mind, we started our investigation on finding a device or a strategy that would allow us to easily or less invasively provide primary closure of the fascia when patients are intentionally left open. So the science behind our device comes from the idea that the abdominal cavity is a cylinder. And when you cut that cylinder in the middle on the linea alba, you actually create what's called hoop stress. So the hoop stress is a circumferential stress tangent to the surface of that cylinder. And what we have to overcome is that hoop stress. So we looked at the tension required to bring the fascia together in an animal model using swine, and that enabled us to find out how much pressure we would need in order to reapproximate the fascia, and we distributed that tension or that force over a larger area so that we could preserve the fascia, preserve the muscle, and preserve the skin while moving the abdominal wall together towards the midline. So we worked with some engineers here at U of T, and they did the calculations necessary, and I'm not gonna go through these formulas. They've explained it to me several times, and sometimes I think I understood them. Nonetheless, the end result was that the mechanical forces applied to the skin, and there are several publications showing that if you apply forces on the skin, they can be effectively transmitted to the fascia, which is obviously deep down, through interconnected load transmission collagen in subcutaneous tissue. So these are anatomical studies that have been done. And we calculated the force, the pull-out force of a single loop of stitch, non-absorbable, placed on the linea alba. And then with our technology, we distribute that force along the entire rectus abdominis muscle sheath or abdominal wall, and it results in a traction of approximately 12.4 pounds of force per centimeter square, which is enough to medialize the fascia and to provide primary closure of the abdominal wall without injuring the fascia. One key point here is represented on this slide. Mobilization of muscles and fascia is easier before retraction and contraction occurs. And this is the key point of this entire talk. The preemptive or the prophylactic approach to the open abdomen will lead to more success. And it's so important that this is applied early, that when we do CT scans of patients with AbClo on them and the device is CT compatible, if you look at the yellow circle representing the skin edge and the red circle representing the muscle or fascial edge, they're exactly one below the other. So there's no shearing of the skin. You're moving the entire abdominal wall together because it's not frozen, given that the device is applied early. So